Hello, friends. A very warm welcome to all of you from Team Nextillo. I'm Dr. Nachiketa, your faculty for surgery with Nextillo, your one-stop solution for different medical exams. Today, in this lecture, we are going to cover the topic of intestinal obstruction and some causes of it. The word obstruction means blockage. Now, this blockage may precipitate anywhere throughout the GI tract from the esophagus up to the anus. But for the today's lecture, we are only going to be concerned with the small and the large intestine. Okay. So the obstruction of the obstruction of the intestine may involve the small or the large intestine, any one of these two. Okay. Amongst these two, the commonest obstruction that we see is the small bowel obstruction, which accounts for almost 70 to 80% of all the obstructions, and the most common cause of the small bowel obstruction are the post-operative adhesions. As far as the large bowel is concerned, the most common cause of obstruction of the large bowel are tumors, especially the malignancies. Now, for practical purposes, we can classify the obstruction in a number of ways. The obstruction may either be complete or it may be partial. The other way to classify the obstruction is that the obstruction may be mechanical. The obstruction may be non-mechanical. What is the difference between these two? The mechanical obstruction, which is also known as the dynamic obstruction. In this type of obstruction, there is a physical obstruction of the lumen of the intestine, be it the large intestine, be it the small intestine. There is something physical which is present. Either there is a stricture or a tumor or any foreign body or anything. For the non-mechanical obstruction, which is also known as the adynamic or the pseudo-obstruction or the functional obstruction, in this, what happens is that there is a decreased peristalsis of the intestine, and hence features of obstruction precipitate as the intestine is not moving due to some reason. The functional obstruction of the small intestine is known as the paralytic Alias, and the functional obstruction, that is the non-mechanical obstruction of the large intestine, is known as the Ogilvy's syndrome. Okay, so this is the difference, that the obstruction is of two types, either mechanical or it may be non-mechanical. Mechanical called the dynamic, the non-mechanical called the adynamic. In mechanical, there is some physical obstruction of the intestine, whereas in the non-mechanical, the peristalsis of the intestine has decreased. Now, this mechanical obstruction that we have, this mechanical variant, this can be further classified into three different variants dependent upon where exactly the etiology is located. The etiology could be inside the lumen, like a parasite obstructing it or a stone obstructing the intestine, or the etiology can be in the wall of the intestine, like strictures, tumors. These are known as the intramural causes. And the third variant of mechanical obstruction are the extramural causes, like there is retroperitoneal fibrosis or adhesions, which we have just seen are the most common cause of the small bowel obstruction. They are all the extramural causes, meaning thereby outside the intestine, but blocking the intestine. Now, coming up to our small bowel obstruction, the small bowel obstruction, just as we have seen right now, could be either mechanical or it may be non-mechanical. The adynamic and the dynamic variant. The dynamic obstruction was further classified into three variants: the extramural, the intramural, and the intraluminal. The extramural causes of the small bowel obstructions commonly include are adhesions, hernias. Adhesions, as we already know, are the most common cause of the small bowel obstruction. Then comes the second variant, the intramural, that is in the wall of the small intestine. These are things like strictures, intussusception, tumors. And the third variant, as we already know, is the intraluminal, like the gallstones, the foreign bodies, parasites, or meconium. Now, this small bowel obstruction can also be due to developmental defects, like the duodenal atresia, where the foregut fails to fuse with the midgut. And ultimately, these two portions, they don't fuse, and hence they are not communicating. And there is an obstruction of the small bowel. The adynamic or the non-mechanical causes, that is the paralytic ileus that we have, or the pseudo small bowel obstruction that we have, it is due to electrolyte disturbances. It may be due to myopathies. It may be due to different types of neuropathies. So that means there are varied number of causes for the obstruction. It could be mechanical, extramural, intramural, intraluminal, or it could be adynamic, non-mechanical, paralytic ileus, which is further due to electrolyte disturbances or myopathies or neuropathies, things like that. Now, whatever be the cause of the small bowel obstruction, be it dynamic, be it adynamic, with minor differences, the clinical presentation for both of them are the same. The initial precipitating features for the small bowel obstruction are pain, nausea, and vomiting. This pain that precipitates with the small bowel obstruction is usually colicky and is located in the central area of the abdomen. And along with this pain, nausea and vomiting is present. Now, more proximal the small bowel obstruction is, that means if the obstruction is in the jejunum, that is the proximal area, or if the obstruction is in the ileum, like just before the ileocecal wall, then it is a distal small bowel obstruction. More proximal the obstruction is, more is going to be the nausea and vomiting. And as we keep on moving distally, the nausea and vomiting decreases and the distension of the abdomen increases. And therefore, nausea and vomiting are more in the proximal obstructions in comparison to the distal obstructions. Whereas the distension is more in the distal obstruction in comparison to the proximal obstructions. Remember this as a rule, that nausea and vomiting, the more distal you go, it decreases. Especially so, if the large bowel is involved, then nausea and vomiting are very late. Distension, on the other hand, the more distal we go, the distension is more. And likewise, as an analogy, if the large bowel is obstructed, then the distension is going to be more. Further on, there are two features: constipation and decreased bowel sounds. Now, over here, constipation as such is a rule of complete bowel obstruction. Now, what happens here with these two features, the constipation and the decreased bowel sound? Initially, in place of diarrhea, in place of constipation, we have diarrhea. And initially, the bowel sounds are increased. The reason being that as soon as the obstruction precipitates, The small bowel or the intestine tries to overcome the obstruction by increasing the peristalsis. When the peristalsis increases, colicky pain precipitates, diarrhea precipitates, and the bowel sounds are increased. But as the time passes and the intestine to say become tired out, constipation precipitates and decreased bowel sounds precipitate. Further on, the patient may also have or develop fever and features of sepsis. Now, for this also, what actually happens? That over time, as fluid accumulates inside the lumen of the bowel, and ultimately the bowel wall is compressed, leading to decreased vascular supply, and the bowel wall may undergo necrosis, leading to translocation of bacteria from the intra-intestinal compartment to the extra-intestinal compartment, that is the peritoneal cavity, and ultimately sepsis precipitates. And if this keeps on going for a very long time, ultimately septic shock may also precipitate. Therefore, this is a very dangerous complication. As the obstruction passes on, the time passes on, dangerous complications keep on developing, especially so sepsis along with septic shock and hypovolemic shock. This is the next important complication of the small bowel obstruction, that is the electrolyte imbalances, dehydration, and ultimately hypotension. Now, for this also, what actually is happening is that the patient is vomiting. When the patient vomits, there is going to be electrolyte loss along with loss of water. Further on, above the level of the obstruction, there is accumulation of fluid. And because of this accumulation of fluid, there is further water and electrolyte loss. And these two together, they lead to an amplified electrolyte imbalance and dehydration. The main electrolyte abnormalities in the small bowel obstruction are sodium, water, and chloride loss. This we have to keep in mind when we are going to manage the patient, that what are the electrolytes that we have to concentrate. So mainly it is sodium and chloride, and along with that we have water, fluid. So this is a gross picture you can see over here for the bowel obstruction. This is a very lean and thin patient, and therefore the distended bowel loops over here are visible in the abdomen. And this small bowel obstruction has precipitated due to hernia over here, as you can see with this arrow. This is the hernia which has caused the obstruction of the small intestine. As this is central in location, the distended loops are visible here in this gross picture. You won't see it in all the patients. This is going to be seen only in a very lean and thin patient. Fine. So now when this person has presented to us, what to do and how to confirm the diagnosis and investigate the patient, what we should do. The investigations. By far, the most common initial investigation done for a suspected obstruction is the X-ray abdomen. X-ray abdomen is the investigation of choice for a suspected patient of intestinal obstruction. That means be it small, be it large, the investigation of choice and the commonest initial investigation done is the X-ray abdomen. The findings that we can see in this X-ray, that there will be distended or dilated bowel loops. The cross section of these bowel loops will be more than 3 centimeters in size. I'll just show you an X-ray where you can see it better. Further on, we'll see multiple air fluid levels. Absence of air in the colon will be seen, as there is a blockage in the small intestine. the colon is going to be empty distal to it. There won't be any air in the colon. So there is absence of air in the colon. Volvuli connivente may be seen. We'll see this also in the X-ray. And the loops that are dilated are mainly seen in the central area of the intestine. Further on, we can also perform a CT scan. The CT scan, no doubt, is more specific and more sensitive. So remember this for the questions. The investigation of choice for the bowel obstruction is X-ray. But sensitive and specific investigation is CT scan. In most cases, the diagnosis can be fixed by the X-rays. But if you want to check out that what exactly was the cause of it, then CT scan is going to be better. It may show us the exact etiology. And one thing that we have already discussed, that absolute constipation is a cardinal feature of intestinal obstruction. But remember this, that this rule is not always true. The rule that absolute constipation is present in intestinal obstruction does not apply in a number of scenarios, like the Richer's hernia, partial obstruction, mesenteric vascular occlusion, functional obstruction associated with pelvic abscess, or any type of functional obstruction. So there are a number of conditions in which the absolute constipation will not be present. Okay. But otherwise, absolute constipation is a cardinal feature of intestinal obstruction. This is our X-ray of the intestinal obstruction, the small bowel obstruction. You can see these dilated loops over here with the multiple air fluid levels. All of these are seeing over here, showing that the bowel loops are dilated. Now you can see these bowel loops one above the others. This is what is known as the stacked appearance, or you can say staircase appearance, like a ladder. Okay, one above the other. These lines that you see over here, giving an appearance like that there are coins that are kept one above the other over here. Over here also you can see one above the other, different lines over here. All of these lines which cross the whole of the cross section of the intestine are known as the volvuli connivente. Okay, so these lines, these are the volvuli conniventes and the dilated bowel loops. These are seen only in the small intestine. They are not going to be seen in the large intestine. In the large intestine, we find the haustras. Okay. So now once we have making a diagnosis of the small bowel obstruction, how to manage it? The management of the small bowel obstruction. The first thing to be done over here is that the patient should be made nil per oral. NPO, nil per oral. Nothing should be given from the mouth. And the patient should be taken up for the parenteral nutrition. Rice tube, nasogastric tube should be inserted, and the gastrum should be aspirated. Whatever fluid has accumulated proximal to the obstruction, we'll try to remove, aspirate the fluid and decompress the proximal section. And fluid resuscitation should be done. IV fluids should be given to the patient. When the patient is stable, then surgery should be done. Surgery should be done as soon as possible once the patient is stable. And the surgery that we are going to perform definitely is going to depend upon the cause. We'll see some causes later on. So the surgery is going to be dependent upon the cause. And remember that once the surgery has been done, it should be our effort that as soon as possible, we should start enteral nutrition after the surgery. The earlier we start the enteral nutrition, earlier the peristalsis is going to come back. In some cases of the small bowel obstruction, we may try for the conservative management in the form of nasogastric decompression and fluid resuscitation. That is the decompression of the proximal section along with fluid resuscitation and the parenteral nutrition. Now, this is recommended in some specific scenarios, like we have a partial small bowel obstruction, or we have an obstruction occurring in the early post-operative period. We may have this conservative management may be tried in intestinal obstruction due to Crohn's disease, and it may also be tried in intestinal obstruction due to carcinomatosis. So the conservative therapy may be tried in a number of scenarios where for a period of somewhere around 4 days, 1 week, we try to go with a non-surgical management. But if the patient does not respond, then we go in for surgeries. And if it is post-surgery, then we go in for a reoperation. The conservative management is the same: nil per oral, total parenteral nutrition, decompression of the proximal section, and fluid resuscitation. Now, as we have seen that obstruction may also precipitate in the early post-operative period, that we have performed a surgery on the abdomen and ultimately features of intestinal obstruction has precipitated. What to do in this scenario? The early post-operative obstructions that we see are usually functional and they are usually partial and rarely associated with strangulation and decreased blood supply. And therefore, we try in extended non-operative therapy for a period of 2 to 3 weeks. If the patient does not respond, then we go with surgery. This extended non-operative therapy is bowel rest, nil per oral, decompression of the proximal section, hydration, that is fluid therapy, and total parenteral nutrition. So if there is a complete obstruction, but over here, or if there is a sign of peritonitis, or the patient is not responding in 2 to 3 weeks, then we go in with surgery. So this is a specific scenario that this was a post-operative obstruction of the small intestine, which is usually a functional obstruction. What we do in this scenario? Okay. Now we are talking about this fluid therapy over and over out. And there was one more thing. The two important complications that we have for the small bowel obstruction was that the patient may precipitate shock and the patient may have sepsis. What to do for these two? Shock is to be managed by fluid therapy. The fluid therapy in the small bowel obstruction. We know that the main electrolyte imbalance in the small bowel obstruction is sodium and chloride loss. And therefore, the appropriate replacement fluid in the small bowel obstruction is normal saline or the Hartmann's solution, okay, containing more of sodium and chloride along with water. For the prevention of sepsis, we should go with prophylactic antibiotics. Prophylactic antibiotic is mandatory in all the patients undergoing surgery for intestinal obstruction and otherwise also. The reason being is that we are trying to somehow decrease the chances of sepsis. This is just a prophylaxis. Okay. So this is the small bowel obstruction. Once again, just very fast re-enumerating it, that we have the mechanical obstruction, we have the non-mechanical, dynamic, adynamic. In the dynamic obstruction, we have a functional obstruction. We have a physical obstruction. These physical obstruction could be either extramural, intramural, and intraluminal. Extramurals like adhesions, hernia, intramural like tumors, strictures, and intraluminal like stones, parasites, meconium. Clinical presentation, the five important things to remember: pain, colicky, central in location, nausea and vomiting, more with proximal, less with distal, distension, less with proximal, more with distal, constipation, but initially diarrhea, decreased bowel sounds, but initially increased. Investigation of choice, X-ray. CT scan is more sensitive. In the X-ray, dilated bowel loops, cross section more than 3 centimeters, central in location, valvulae conniventi seen, and multiple air fluid levels seen. Management, nil for oral, total parenteral nutrition, the decompression of the proximal section, and as soon as possible, surgery. In some scenarios, conservative management may be tried. So this is what is the management of the small bowel obstruction. Now for the large bowel obstruction, actually most of the things remain the same. The large bowel obstruction can also be either mechanical or non-mechanical, dynamic or adynamic, that is functional or pseudo, Ogilvie's syndrome. For the dynamic, that is the mechanical obstruction of the large bowel, varied numbers of etiologies are there. But we know already that the most common cause of the small bowel obstruction are carcinomas. They account for somewhere around 60 to 80% of the cases of the large bowel obstruction, large intestinal obstruction. Then they may be also due to strictures, like strictures seen with diverticular disease or with the inflammatory bowel disease, that is the Crohn's colitis or the ulcerative colitis. Then they may be also seen with different hernias if the large bowel is involved. Then they may be due to volvulus. Volvulus means nothing. Volvulus is technically the rotation of the intestine on its axis, like this, that the intestine has become rotated and ultimately become obstructed at points. Volvulus may precipitate in the cecum. It may be seen with the sigmoid colon. Sigmoid volvulus being the most common volvulus amongst all. Volvulus may precipitate in the stomach. It may precipitate in the midgut around the jejunum. Then this may precipitate around the cecum, and it may also precipitate with the sigmoid colon. Amongst all of these different types of volvuluses, the commonest volvulus is the sigmoid volvulus. Then there are some congenital causes also for the large bowel obstruction, like we may have anal stenosis, we may have the Hirschsprung's disease, in which the neurons are lacking in the muscular layer of the intestine, and hence the bowel is tonically contracted, giving rise to obstruction. So these are all different varied etiologies. Most important amongst these to remember is that the most common cause of large bowel obstruction are the carcinomas, cancers, large bowel tumors, adenocarcinoma being the most common cause. Now, the clinical presentation for the large bowel obstruction this patient will have distension of the abdomen. If you remember from the small bowel, as we keep on moving distally, the distension keeps on increasing, more distension, less nausea and vomit. So this fellow has more of distension. But again, remember that a sigmoid obstruction, there would be more distension in comparison to the cecal obstruction. In the cecum, we may have colicky pain, we may have nausea and vomiting. But as we keep on moving distally, distension increases. And usually the commonest area where we see the malignancies are the sigmoid side, and therefore we have the distension as a more common presentation. Then this patient will have constipation, nausea and vomiting. Just once again telling you, vomiting is a very late feature. Pain may be there. The pain which precipitates here is mild. This pain is mild in nature, but not in all the cases. Sometimes it may be colicky, like with cecal volvulus. Cecal volvulus will precipitate or present to us with colicky pain and nausea and vomiting. So this is not the case in all the scenarios, but usually the pain is mild with the large bowel obstruction. And if there is perforation, then we will have signs of peritonitis, and along with that, we will also have dehydration and hypotension. So overall, the features remain the same. The only thing that changes over here is that which feature is predominant. Nausea, vomiting, pain was predominant in small bowel. In large bowel, the predominant features are abdominal distension and constipation. Nausea and vomiting late, pain is usually mild. And once again, how to diagnose it? We already know that the investigation of choice is X-ray abdomen. Here you can see that this is a dilated distended bowel loop here. The findings that are going to give us a clue that this is a large bowel obstruction is that the loops are mainly peripheral in location, actually to be seen on this side or this side of the abdomen, not actually in the center as you see in this X-ray. Though this is a large bowel, transverse colon is what you are seeing here. This actually over here is that there is a tumor in the descending colon which has given rise to the obstruction. This loop that has become distended, the cross section from here to here is going to be more than 6 centimeters. For the small bowel, it was 3 centimeters. For the large bowel, it is 6 centimeters. For the cecum, remember, it is going to be more than 9 centimeters. Small bowel 3, large bowel 6, appendix 6, cecum 9. This is the rule. House may be visible. These small lines that you see here in this X-ray, you don't find the volvuli conventi which cross the whole of the intestine. You see these lines here, just over here by the side. These are the haustra. So haustrations are visible here. To confirm the diagnosis, we may utilize the CT scan. CT scan, no doubt, is more sensitive and more specific. It may tell us even the etiology exactly, what was there, what caused the obstruction. One more X-ray or 2 more X-rays that you can see. This is a volvulus over here, a cecal volvulus. This is the omega sign visible over here. Or you can say the bent inner tube sign. The cross section of this dilated loop you can see is around 7 centimeters, more than 6 centimeters. And the lines that you see over here, these lines, like in the second picture, you can see more clearly these lines. This is a double contrast. These lines over here, these are the haustras. And actually here you see a napkin ring sign here, or the apple core sign too, which is a sign of the adenocarcinoma of the colon. The cancer has invaded the whole of the ball and the lumen is so much contracted. This is where the cancer is present. Haustras are visible and the dilated loop here with a diameter of more than 7 centimeters. The haustras not crossing the whole of the cross section of the intestine. You will better visualize these two here. You can see the haustras here. These haustras, this is one loop here. Then we have a loop here. We have a loop here. You can see these lines, but they are not crossing the whole of the cross section. These are the haustras. Whereas in this second picture, you can see that these lines are crossing the whole of the cross section. These are the volvuli conniventes. So this is how we make in a difference, because this is the transverse, you can see small bowel loops. So once we have made a diagnosis that this is a large bowel obstruction, the management follows the same guidelines, that the patient is to be made nil per oral, total parenteral nutrition should be started, fluid resuscitation should be done, Rice tube decompression of the proximal section should be done, and prophylactic antibiotics should be given. As soon as the patient is stable, surgery should be done. Okay. The surgery, once again, here also is going to be basically dependent upon that what exactly was the cause of the obstruction. There are a number of scenarios, but commonly what we see here, that it is the cancer which causes this. And common surgeries that are used for the cancers of the sigmoid colon. We may perform a Hartmann procedure for the sigmoid colon tumor, where you can see in this picture, this sigmoid part of the colon is removed. This is known as the proctosigmoidectomy. This proctum and the sigmoid colon removed. Then this proximal portion is brought out over here with colostomy. The colon is brought out colostomy and colostomy, and this is the colostomy pouch covering this opening. And this distal pouch that we have, this stump that is left here, is closed here from the upper side. This is the closure of the anorectal stump. So these are the three things to be done in the Hartmann procedure. In some scenarios, a reversal of the procedure may be done when the colostomy is closed, and this tube then is going to be brought down and anastomosed with this distal section. But usually this is just an end surgery. Other procedures that we may utilize over here is resection of the involved segment with primary anastomosis. Cut the segment, anastomose it immediately. Now, this could be right hemicolectomy with iliotransverse anastomosis. Now, this is going to be done if the tumor is in the right side of the colon. The whole right side colon is removed and the ileum is brought up to the transverse colon and anastomosed there. Or we can go with the colectomy, removal of the whole of the colon, and anastomose the rectum with the ileum with the rectum. Iliorectal anastomosis. So these are different types of procedures. There are a number of varied procedures. These are just some examples. Hartmann procedure is asked again and again. So remember this, that Hartmann procedure, there are three things to be done. Fine. So these are the basic fundamentals of the large and the small bowel obstruction. Till now that we have seen, we have mainly talked about the mechanical obstruction. Now coming up to the non-mechanical, that is the adynamic obstruction, pseudo-obstruction. Pseudo-obstruction may also involve the small intestine, which is known as the paralytic Alias, or it may involve the large intestine, which is known as the Ogilvie's syndrome. And as you already know, there are a number of etiologies responsible for it. The pseudo-obstruction, both in the small and the large intestine, can be due to trauma. It may be after or post-abdominal surgeries. It may be due to electrolyte imbalances like hypokalemia, hyponatremia, hypomagnesemia, hypermagnesemia. It may be due to infection or sepsis. It may be due to pelvic inflammatory diseases or pelvic inflammatory disorders. Then this may be due to myopathies. It may be due to neuropathies. Then this may also precipitate as a sequelae to some conditions which cause severe abdominal pain. These are diseases that lead to abdominal pain and ultimately cause the paralysis of the intestine, like cholecystitis, appendicitis, pancreatitis, diverticulitis, and ultimately intestinal ischemia may also lead to it. Okay, so these are different varied etiologies. Amongst these etiologies, the most important to remember are the different electrolyte imbalances, the hypokalemia, hyponatremia, hyper and hypomagnesemia, along with abdominal surgery or the post-operative functional obstruction. Now, how to manage this? The first thing to remember is electrolyte imbalances. If there is an electrolyte imbalance, especially post-surgery, correct that electrolyte imbalance. Then we may utilize some drugs, like we may utilize metoclopramide. Metoclopramide may increase the intestinal motility, but in some cases may worsen the paralytic ileus. It can be tried. Erythromycin, cisapride, these are prokinetic drugs that we may utilize. Neostigmine can be given to the patient 2 to 2.5 mg IV over 3 minutes. But remember with neostigmine that it is not to be given if there is perforation or mechanical obstruction. Neostigmine is to be given only when functional obstruction is there, pseudo obstruction is there. It is not to be given in the mechanical obstruction. So it is contraindicated if there is a suspicion of perforation or mechanical obstruction. And if the patient is not responding to the correction of the electrolyte imbalances and these drugs being given, then we have to go with surgery. As far as the post-operative functional obstruction is concerned, there are a number of methods or measures that we can adopt to decrease the risk of post-operative ileus. During surgery, minimize the handling of the bowel, as minimal as you can touch the bowel. If possible, go with a laparoscopic approach, like laparoscopic cholecystectomies, laparoscopic surgeries, all different variants. And avoid excessive intraoperative fluid administration. Once the surgery has been done, post-surgery, what should be done is that as soon as possible, enteral feeding should be started. Remember, I told you that after surgery, as soon as possible, start the enteral feed, remove the RT. The earlier we start the enteral feed, more are the chances of peristalsis coming back earlier. Use epidural anesthesia. Avoid excessive intravenous fluid administration. Correct if any electrolyte abnormalities are present. And we can also give mu-opioid antagonists so that there is a reversal and the peristalsis comes back. So this is in a broad term, the small bowel and the large bowel obstruction. And then we will definitely go in with some clinical conditions that are associated with the small and the large bowel obstruction. Right now, we are giving access at just ₹89. And especially so, as we know that the conditions over there in Ukraine are not very congenial. This is just trying to help out you guys and all of you people. You can try the app for 3 months at just ₹89. So now coming back to some specific causes of the bowel obstruction and some general questions that may be asked. The first important thing is, what are the radiological findings of paralytic ileus? The radiological findings here are that the bowel loops are distended with multiple air fluid level and gas is seen in the rectum. Remember that with the mechanical obstruction, there is no gas in the colon or the rectum. But with partial obstruction and functional obstruction, there is gas seen in the colon and the rectum. The second question is, how is bowel obstruction, that means mechanical obstruction, different from paralytic ileus? Mechanical small bowel obstruction different from the paralytic ileus. In paralytic ileus, just as I said, that the gas is seen in the rectum in paralytic ileus. But in mechanical obstruction, there is paucity of gas. That means there is no gas in the colon or the rectum beyond the point of obstruction. So this is the basic difference, mechanical and the function, if it is asked. Further on, what are the radiological findings in the small bowel obstruction? The first important finding is multiple air fluid levels. As you can see here, we have a step ladder appearance, the dilated bowel loops one above the other. This picture you have already seen, this second one. Now this one, you can see that this is a step ladder type of appearance. Because of the valvulic conventi, we have the stacked appearance. Then string of pearl sign may be seen. This string of pearl sign is caused by slow reabsorption of the intraluminal air, leaving small air bubbles trapped in the valvular conventi. You can see it over here. Minute dots, black dots that you see here. This is the string of pearl appearance with the small bowel obstruction. Do not confuse the string of pearl appearance with the string of beads sign. I'll just come back to it. The loops that you see in the small bowel obstruction over here, they are mainly centrally located. Okay, multiple air fluid levels and centrally located dilated loops. The dilated loops have a diameter of more than 3 centimeters in size, and there is absence, that is paucity of gas in the colon, and the colon appears to be collapsed. These are the findings of the small bowel obstruction in the X-ray. Do not confuse this string of pearls sign with the string of beads sign. String of beads sign, which is also known as the chain of lakes sign, is seen with pancreatitis here. Okay, so this is where we are seeing it. Fine. So these are the different pictures. Remember, string of beads, pancreatitis, string of pearls, small bowel. Then what are the useful imaging procedures in the evaluation of the small bowel obstruction? The first important investigation of choice was plain film. Plain film serves as the screening tool. It is the investigation of choice. It is the most common initial investigation of suspected bowel obstruction. Fine. Supine and erect films are done. And what we look for is dilated loop of bowel and air fluid level. The sensitivity of the plain film, plain X-rays ranges from 41 to 86%, and the specificity ranges from 25 to 88% to make in a diagnosis or to exclude a diagnosis of small bowel obstruction or the large bowel obstruction. The second investigation utilized is the CT scan. CT abdomen provides a more detailed information, and it can even show us the etiology. Suppose if a malignancy is present, the CT scan is going to show us the malignancy itself. Then we may also perform the CT scan with per oral, that means the contrast is given through the oral route, and the IV contrast. This has a sensitivity and specificity of 183%, meaning thereby sensitivity of 100%, specificity of 83%. If the CT scan with per oral and IV contrast is normal, then it is highly unlikely that we have an obstruction. It is very sensitive to rule out the diagnosis, that the diagnosis is not there. And one last thing over here, that how do you distinguish the large bowel from the small bowel? Small bowel is central in location, as we all know, and the large bowel is peripheral in location. Fine. Then valvular connivences are seen in the small bowel. As you can see in this second picture, the valvular connivences crossing through and through across the weight, and house straws are seen in the large bowel, which do not cross the bowel. They are partially across the bowel. And diverticulars are seen only and only in the large bowel. Small bowel does not develop diverticulars. Then comes in our Ryle's tube. This is a picture of the Ryle's tube. I believe most of you must have seen it. This Ryle's tube has got a number of markings. Okay, for this we need to remember that what are and the distances, important distances from the oral or the nasal cavity, at what point we are going to have the first obstruction, that means the lower esophageal sphincter, then where do we have the pylorus, and like that, and so that we can judge where is the tip over here. This tip over here of the Ryle's tube, this is going to be radio opaque. This green area that you see here, this is a material which is radio opaque, so that when we take in a picture, we can see that where exactly is the tip of the Ryle's tube placed. These lens over here that we see in the Ryle's tube, the first mark is 40 centimeters from the tip. That means from this over here, from the tip, it is 40 centimeters like that going back. This is the tip. This indicates that the Ryle's tube has passed the cardiac orifice, that is the lower esophageal sphincter, and is now in the stomach. The second mark is 50 centimeters. When we reach this mark, we know that the tube is in the body of the stomach. The third mark is 55 centimeters, and now we know that the tube is at the pylorus. And then the fourth mark is 65 centimeters, which means that the tube has reached the duodenum. Now, these Ryle's tube, or for that matter, any type of such instruments, they comes in different shapes and sizes and colors. Different packings and colors are there. These colors are going to denote the size. The most important among these to remember is the starting from green and going up to violet. Green is 14 French gauge, orange 16 FR, red 18 FR. The size is increasing. Yellow is 20 and violet is 22. Most commonly used among these are the orange, red, and yellow ones, 16, 18, and 20. So these are different colors, and we will have to remember mainly these three colors. And these colors, mind you, have to be remembered for a number of things, like the intracath that we utilize. They also come in different colors. The French size technically remains the same for them also. Then this is our flatus tube. Okay, this flatus tube is inserted through the anal opening, through the anus, and this is to decompress the distal area, to remove the air that is trapped in the distal area. And this is our Mellicot's catheter. Okay. So these are some basic fundamentals regarding it, the different things that are important for the intestinal obstruction. We definitely have to see in varied etiologies. There are a number of varied etiology. We try to classify them into different groups. There are some generalized etiologies, like we may have the Meckel's diverticulum, we may have the sigmoid volvulus, the cecal volvulus, the Hirschsprung's disease, things like that. Then we have some diseases which we are going to see with the pediatric surgery, like the duodenal atresia, the midgut volvulus, the Hirschsprung's disease also, necrotizing enterocolitis. Then there is one group of diseases which is the inflammatory bowel diseases, the Crohn's colitis and the ulcerative colitis. Then we have one very important set of diseases, the intestinal tumors, the tumors of the small intestine and the tumors of the large intestine, the adenocarcinomas and the benign tumors like leiomyomas. So we have to see all of these one by one later on. We'll definitely be covering them. Now let us just see one thing over here. This is a question for you people, whatever we have studied till today. What exactly is the diagnosis for this finding? As an aid to you, here what you see is the step ladder sign that is seen in the small bowel, and what you see here is the large bowel, meaning thereby that this is small bowel seen here and this is the large bowel. This is just going to be a clue for it. You are supposed to make in a diagnosis that the patient is suffering from. And if you can give me a very probable specific diagnosis, it would be best for us. So once again, enumerating the things, small bowel, large bowel obstructions, they can be classified based upon a number of variants. The bowel obstruction can either be partial or it may be complete. Then this bowel obstruction may be either a mechanical obstruction or it may be a non-mechanical obstruction. Mechanical obstruction, there is a physical obstruction of the bowel. In non-mechanical, which is also known as the pseudo or the functional obstruction. For the small intestine, paralytic Alias. For the large intestine, the Ogilvie's syndrome. There, the peristalsis has decreased due to some reason like electrolyte imbalances or because of myopathies, neuropathies, something has happened. For the mechanical obstruction, we may have the extra mural etiologies like adhesions, hernias. Then we may have the intramural etiologies like the tumors, be it of small intestine or the large intestine, intussusception, like the ileocolic involving both the small and the large, colocolic involving only the large, ileo-ileal involving only the small. So these are the intramural causes. Then we have the intraluminal causes like the gallstones. The most common site of impaction of gallstone in the intestine is the terminal ileum at the ileocecal junction. Parasites may block it. So these are different causes. Developmental defects like the duodenal atresia, jejunal atresia, duplication of the intestine. Clinically, we have pain, nausea, vomiting, distension. Small intestine, pain is colicky. Large intestine, pain is mild. Nausea and vomiting, the proximal we move, more is nausea and vomiting. As we keep on moving distally, distension increases. Large bowel, distension is prominent, pain is less, nausea and vomiting is less. Small bowel, pain is colicky, distension is delayed, nausea and vomiting is early. Then we have constipation, decreased bowel sound. Initially, we have diarrhea and we have increased bowel sound, fluid loss, hypotension, sepsis. Investigation of choice, X-ray. Dilated bowel loops, centrally located more than 3 centimeter, small bowel. Valvuli conventi, small bowel. Peripherally located more than 6 centimeters, large bowel. Haustra, large bowel. Small bowel, non-functional. Air will be present in the rectum and the colon. For the mechanical, dynamic one, air will be absent in the colon. So this is it for today. For the exact etiologies, we will definitely keep on going with further lectures. Remember, Nextillo, download the Nextillo app. There you can find a number of lectures, and we will keep on taking live lectures in the Nextillo app also. There you will find a number of MCQs too. It is your one-stop solution for all different exams like lab, your NEET PG, your USMLE, all the different exams that you may like to appear for. Okay. And right now we are giving the access to the app at just rupees 89 for the next 3 months. Thank you.